conducted at Twin Cities Orthopedics in Minneapolis, Minnesota. The presenters have no relevant disclosures to announce. For a little bit of background on the practice where this study was conducted, it's a large physician-owned practice in the Midwestern United States, employing over 120 physicians. Patients are seen in over 37 clinic locations in 2 states. There are 7 working ambulatory surgery centers, of which 4 are orthopedic surgery centers relevant to this discussion. It has multiple affiliations with regional rehabilitation centers and hospitals, as well as a number of professional sports associations. We've talked a little bit about the setting, and what I'd like to do during today's talk is describe the methods we use to implement a universal screening protocol and continuous monitoring for patients and staff, what the results of this were in terms of controlling the COVID pandemic and resuming elective surgery within our practice, and to extrapolate how these procedures might be used going forward. With a view of the changing nature of these phenomenon, it's important to be able to use this information to extrapolate procedures which might be used in the future. Our study period ran from April 28th of 2020 to December 31st of 2020, during which time 12,115 patients underwent over 13,000 elective surgical procedures. The majority of these were sports medicine, elbow, hand, and wrist surgery, foot and ankle surgery, though all types of elective orthopedic procedures were represented from spine to total arthroplasty. Early in the pandemic, it was especially important to establish guidelines for which elective surgeries were of a more urgent nature. These included acute injuries with any neurovascular compromise, infections and surgical site dehiscence, irreducible dislocations, and highly morbid injuries. It was also deemed important to treat any chronic conditions in a timely manner which carried a high risk of long-term disability and morbidity. Other considerations for the timely reopening of ambulatory surgery centers for elective surgery included relative savings to the healthcare system as a whole, afforded by use of outpatient centers for elective surgery rather than using critical hospital resources. It became clear that it was necessary to implement a universal series of screening protocols and testing for patients and ASC personnel to be able to track the effectiveness of infection control protocols. To this end, we implemented a system in which all ASC personnel, including operating surgeons, would complete bi-weekly COVID-19 RT-PCR tests and complete daily screening questionnaires for any symptoms including fever, cough, or shortness of breath. Personnel were also asked to avoid travel to any high-risk areas and avoid close contact with sick persons. If experiencing symptoms or reporting close contacts with sick persons, employees were asked to go to one of several contactless testing centers which were set up specifically for this purpose. At these locations, employees could receive free testing administered by persons wearing full personal protective gear. Once the vaccine became widely available, all staff were scheduled for vaccination. The other most important part of our protocols was universal patient testing before surgery. The same RT-PCR COVID-19 tests were given to patients no more than 96 hours prior to surgery, and they were asked to quarantine between that interval and the day of their surgery. These tests were administered likewise by employees in full PPE. In reviewing demographics for patients accepted during this time, we found an average age of 52, an age range from 17 to 77, and an average American Society of Anesthesiologists score of 2, which reflects a state of mild systemic disease. Comorbidities during this time varied but reflected just over 33% were current or former tobacco users. 70 unique patients tested positive for COVID-19 out of our total of just over 12,000, for an overall percentage of 0.6%. Of these, 8 were totally asymptomatic at the time they were picked up by the universal screening test. There was an average age of 46 with a slight male predominance, and 27% were current or former tobacco users. Major comorbidities reported were hypertension and asthma. Incidence of new patients detected on the universal screening tests increased towards the end of the study period. This may have reflected loosening of COVID-19 restrictions at a societal level, increasing virulence of later strains of the virus, or perhaps decreasing compliance with COVID restrictions as vaccines started to become more available and lockdowns let up. Across ASC personnel who tested positive for the virus, There were 48 positive tests, of which 41 were unique individuals. This resulted in an overall incidence rate of 6.4%. These include both the mandatory biweekly tests as well as voluntary tests after exposure or development of symptoms. Analysis of the daily self-reported questionnaires demonstrated headache and sore throat were the most commonly reported symptoms. 53 individuals reported close contacts, of which 16 reported development of symptoms and self-quarantined. Any personnel who reported fever, shortness of breath, or cough underwent testing prior to returning to work. The most common symptom reported in ASC personnel who tested positive was headache. During the same period, the Centers for Disease Control reported that the most common symptom in COVID-positive individuals was cough. This may reflect a small sample size among our positive individuals or demographic differences in our population versus the U.S. population as a whole. In all, 0.6% of patients, or 70 individuals, were detected on COVID universal screenings before surgery. By contrast, 6.4% of staff were detected to be COVID positive. This made for a low incidence of patients and staff detected to be COVID positive in an outpatient ambulatory surgery center. We believe that this system offers a reproducible framework for other facilities to continue to provide orthopedic outpatient operations in ambulatory surgical settings. This makes for a safe way to operate ambulatory surgery centers as a crucial part of healthcare infrastructure during pandemic conditions. Our system was dependent on universal testing of patients and continuous monitoring and testing of ASC personnel. Some of the limitations of our study include the patient population. With an average ASA class of 2 or mild systemic disease, the patients may have been healthier than the healthcare population as a whole. In addition, no patient self-reported symptoms were available comparable to what was available through the daily questionnaire of our staff. Symptoms tracked among ASC personnel were self-reported in the daily questionnaire, introducing a self-reporting bias. And additionally, these data were from some of the earlier waves of the pandemic, which may have been less virulent than later waves. Some of these factors may be of importance in consideration of our template and its stated goal as a guide for future pandemics. However, our program does offer some advantages. The daily screening questionnaire is easily available and has simple technology to implement. It relied on the wide availability for sensitive and accurate tests available to track incidence of the disease. It also relied on the ability to set up easily accessible testing centers. So long as these resources are available, our schema may be used as a template for future pandemic outbreaks. While the world was caught unprepared by the COVID-19 outbreak, having templates such as ours available as emergency resources in future pandemics may prevent some of the confusion and disruptions to critical healthcare infrastructure which were witnessed during the COVID-19 pandemic. The authors thank you very much for your time and attentiveness and hope that you find our program and its results useful.